As chronicity is synonymous with central sensitisation, so it is with complexity. If only the role of cervical afferents were considered, then headache and migraine need not become chronic and therefore complex. Many with symptoms qualifying for a diagnosis of migraine say, of course it's my neck, I know it's my neck, but only to be disputed by their general practitioner or neurologist. However, being suspicious of cervical involvement is one thing. What is needed then is knowledge, skill, and a sound logical reasoning process to determine the relevancy of cervical afferents and to treat effectively. Let me take you through the typically frustrating journey of a headache and migraine sufferer. So we have someone who develops head pain or headache, and appropriately they go off to see their general practitioner, who more often than not will refer them to their neurologist, who more often than not will do a scan, which will be negative. So what's happened here so far is that yes, sure, a diagnosis is likely to have been given, but one has to question the value of a diagnosis. In the headache and migraine world, a diagnosis is based on a set of signs and symptoms. It doesn't tell us what we're dealing with. So a label is not particularly useful. And at this point, patients are dedicated to a life of medication. So in an endeavour to find out the reason for the headache or migraine, they'll consult other health care professionals, and they may see an ophthalmologist thinking that their eyes are the issue and may invest in glasses. They may see an ear, nose and throat specialist. If they've got facial pain, they may be suspicious that their sinuses are the cause of their headache. And I hasten to say that true sinus headache is rare. It's overdiagnosed significantly. So the chances are these people will have sinus surgery unsuccessfully. The number of people I've seen who've had one or more sinus surgeries unsuccessfully to rid them of their headache or migraine is significant. There is one ear, nose and throat specialist who refers me his patients before surgery to ascertain just how much of their facial pain is related to their upper cervical spine. Now, women with headache, where the headache is seemingly related to their hormonal cycle, will visit the gynaecologist, and from that point on, their hormones will be artificially manipulated. And this beggars belief, because research shows quite clearly that hormones are not the issue in menstrual migraine. We've seen earlier that the underlying disorder in menstrual migraineurs is a sensitised brainstem, and that the triptans, which desensitise the brainstem, are effective in treating menstrual migraine. This is not about hormones. Children with unexplained abdominal pain are often diagnosed with abdominal migraine, so they may see a paediatrician or perhaps a gastroenterologist, and of course many go off to see the dentist. And all along, cervical afferents continue to be ignored. Now, generally speaking, at this stage, it's still quite frustrating, because there's nothing really conclusive. They still haven't found out, the majority of people still have not found out where the headache or migraine is coming from. They're dissatisfied, they're resigned that this is life, this is my life, I've just got to go home and live with it, which is what they're told. Go home and live with it. So at this point, ongoing medication, clearly chronic depression, anxiety, and suicide. Now, cluster headache is also known as suicide headache, and surveys show that 60 or 70% of people with cluster headache have at some time contemplated suicide. So yeah, are we dealing with a complex situation? You bet. And at this stage, many are sent to the pain management clinic, also known as the Too Hard basket, where they will be assessed by a team of healthcare professionals. And my experience is that this is an unhappy one for headache and migraine sufferers. Now, for those who are suspicious that it's their neck, then they will seek the services of a physiotherapist, a chiropractor, or an osteopath. And at this point, I'd like to raise the significance of unilateral headache. It's absolutely critical that if you find out that if someone who has unilateral headache, can it be on the other side? If sometimes it's on the other side, then this is the most important subjective feature that tells you without a doubt that you're dealing with cervicogenic headache. So a unilateral headache that can swap sides, either between episodes or within the same episode. For example, I see some people On day 1, their migraine's on the left, day 2 it swaps to the right, and day 3 it goes back to the left, and day 4 it's gone. I've also seen people say with a 12, 15 year history of migraine, and for the first 10 years, their migraine was left-sided, but 5 years ago it swapped to being right-sided. Now this headache has alternated, it's not alternating, but it still confirms cervical relevancy. So alternating headache is a cervicogenic headache. So having sought the services of a physio, chiro, osteopath depends on the expertise of the practitioner and their experience with headache, because this is going to dictate the outcome. And of course, if the outcome is unsatisfactory, then we're right back here to, clearly it's not my neck, then I need to get opinions from someone else, and they then seek the opinions of others and potentially are on this road along the top here again. So this journey needn't happen if only cervical afferents were considered in the outset and addressed by someone skilled, someone with experience in looking at the upper cervical spine in headache and migraine.